Hello everyone, welcome back to my YouTube channel. This is Dr. Ashwari Gupta. Today I'll discuss airway disorders. In that also I'll discuss three things. So that is eosinophilic lung disease, allergic bronchopulmonary aspergillosis, and hypersensitivity pneumonitis. These three topics are very much interrelated and have some common features, and that is why they are tested in the exam. And in that also I have focused on the very it pinpointed it to the areas which are asked in the exam. So it's going to be very specific for the medical interest point of view. So without wasting any time, let's get started. First thing is eosinophilic lung disease. What is happening? There is an increase in eosinophil in the lungs. Basic name suggests. So how do you diagnose? The BAL should be, more than 25%. BAL is bronchoalveolar lavage, and even the lung infiltration will be there with eosinophil. So lung tissue aspirated also. So the amount of eosinophilia. There are certain known causes which can cause eosinophilic lung disease. This could be ascariasis, okay, lung fluke, and tropical pulmonary eosinophilia, which is a very deadly disease and often misdiagnosed as acute bronchitis or even asthma exacerbated. But if the physician picked this up in time, it can be managed very nicely with albendazole itself. And then you have nitrofurantoin. Otherwise, you have certain unknown causes which need to be investigated properly. That is EGPA. What we call is jerk straws. The new name for jerk straws is EGPA. Then you have GPA, granulomatous polyangiitis, which is regulars, and then you have CEP, chronic eosinophilic pneumonia. You see reverse patterning appearance in this, while battering appearance is seen in pulmonary edema. Coming to allergic bronchopulmonary aspergillosis, very important topic asked many times. This is a eosinophilic lung disease. Very, as I told, what I'm discussing in the starting of the video, caused by aspergillus fumigators. All right. So, it has this predisposition in the patients of asthma and cystic fibrosis. So, these can be a precipitant. All right, precipitant for allergic bronchopulmonary aspergillosis. So, being an allergic disease, it becomes type 1 in hypersensitivity reaction, and since there is a need of precipitant, it has to have type 3 component. So what you get, what kind of allergic bronchopulmonary disease it can be type 1 plus type 3 hypersensitivity reaction. You can also remember that EBP has 4 words and 1 plus 3 is 4. So that's how I used to remember. And for diagnosis, you can do increase in IgE, alright, more than 1000. IgE is stimulated by IL-5, another important question from patho. So how do you manage? Here the people tend to do mistakes. You give steroids for 12 weeks, no result, then itraconazole. There's no fluconazole, no voriconazole, no other antifungal. So what happens in the exam? They'll ask you they'll give you a case scenario of allergic bronchopulmonary aspergillosis, and they'll ask you management, and somewhere it will show some antifungal drug, and people tend to mark that as the answer, but that won't be the answer. The answer is steroid for 12 weeks, and then if there's no result, then you can give itraconazole. Otherwise, omalizumab can be added to control the IgE part. All right, coming to hypersensitivity pneumonitis, this is another allergic disease. What is happening there is there's repeated exposure, you know, to certain tests, and then the lung parenchyma become hypersensitive to that. So that results in pneumonitis, pneumonia kind of. Then what is happening here? There's a type 4, so there is a granuloma formation in this. If you see the histopathology section of a patient with hypersensitivity pneumonitis, then you will see granuloma, and there is a precipitate always, since there is a repeated exposure. So it is type 3 as well. So this has a long name, 4 plus 3 is 7. So that's how you can remember the hypersensitivity pneumonitis is a long name, and 4 plus 3 is 7. So it has hypersensitivity type 4 plus type 3. HRCT में you see mosaic pattern, and इसमें steroids दोगे to suppress the immune response and relieve the patient. So that's it from me today. A very small topic, since I have not much time. I'm very busy in my duties, but somehow it's like I take it as a challenge for myself to record the video even if there's a busy schedule. I'm happy from my part that I did this, and all the best to you guys. Hopefully, I'll come with something more worthwhile in the next video. And even this one, these three topics may seem very small, but they are highly productive from my point of view. And do this, read other things also. I'll cover whenever I get time, and hopefully next week itself. All the best to you. Prepare well. See you on the other side. Bye bye. Take care.